Hello and welcome. This lecture will be part of a four-part series on clinical genetic testing. So without further ado, let's get started. As you know, each of our cells contain chromosomes, which consolidate long strands of DNA. These long strands of DNA can be further divided into segments called genes. One of the easiest ways to help patients understand genetics is by using familiar analogies like a book. Imagine your entire genetic makeup is like a book called the genome. The genome contains all the information your body needs to grow, develop, and function. Inside the book, there are chapters. These are like the chromosomes, which organize the genetic information. Each chromosome, or chapter, holds a set of instructions. If we zoom in even further, the sentences in each chapter represent genes. These genes are the specific instructions for how the body works. For example, one gene might carry the instructions for how your body processes a certain medication, while another gene may dictate eye color. This analogy helps patients break down the complexity of genetics into manageable parts. Now, let's clarify the difference between genetic screening and diagnostic testing, as both play crucial roles in our field. First, we have genetic screening. This type of testing is typically performed on asymptomatic individuals or in the general population. The primary goal here is to help us predict whether further testing is necessary. Common examples of genetic screening include carrier screening, prenatal screenings like analyte screening and cell-free fetal DNA testing, also known as NIPT, as well as ultrasounds and newborn screenings. Depending on the results, individuals may be categorized as high risk or low risk, which can guide further steps in their care. On the other hand, we have diagnostic testing. This is generally reserved for individuals who are symptomatic or for those where we need to rule out a familial variant. Diagnostic testing is offered based on specific indications and typically yields more definitive results, essentially a yes or no outcome regarding the presence of a genetic condition. In summary, while genetic screening helps us identify individuals who might need more in-depth testing, diagnostic testing gives us a clear answer about whether a condition is present. Understanding these distinctions is vital for us as genetic counselors to provide appropriate guidance and support to our patients. Some of the common genetic testing approaches that we will cover in this four-part series include karyotype, chromosome microarray, or CMA, fluorescence in situ hybridization, or FISH, single gene testing, multi-gene panels, and genomic sequencing, including whole exome sequencing and whole genome sequencing. We will also be covering some more specialized genetic testing approaches, including methylation studies, uniparental disomy testing, expanded repeat analysis, chromosome breakage analysis, telomere analysis, biochemical analysis, tumor or somatic testing, RNA testing, long-range PCR testing, and multiplex ligation-dependent probe amplification. This chart here is going to summarize the advantages and disadvantages of each kind of testing, and we'll go further into that a little bit later. When it comes to genetic testing, one important decision is which type of cell sample we'll use. Different types of testing may require different cell sources, and each one has its own advantages. In most cases, we can use blood to do genetic testing. This is because white blood cells, particularly T lymphocytes, give us enough DNA to work with, and it's minimally invasive, meaning it's easy to collect without causing much discomfort. Most of the time, a simple blood draw is all we need. However, there are some situations where a blood sample isn't enough. For example, if a person has had a hematopoietic stem cell transplant, their blood might no longer reflect their original genetics. Also, for individuals with mosaicism, where different cells in the body have different genetic makeups, a blood sample might miss important variations. In these cases, a skin biopsy may be needed. This procedure is more invasive since a dermatologist or primary care doctor needs to take a sample of skin cells, but it can provide better results for certain conditions. For prenatal testing, we have a few options depending on the situation. For methods like chorionic villi sampling or amniocentesis are more invasive but provide a clear look at fetal cells, while cell-free fetal DNA testing is a less invasive option that uses the mother's blood to analyze fetal DNA. These options help us test for genetic conditions in developing babies. Choosing the right cell source depends on the patient's medical situation and the genetic information we're looking for. The goal is always to find the least invasive method that will still give us reliable results. Saliva is preferred over buccal swabs if the donor can provide a sample or if clinically indicated, as it typically yields more DNA. The purity of genomic DNA from saliva is comparable to that from blood, though blood samples generally produce a higher DNA yield. The oral cavity contains both leukocytes and squamous epithelial cells. While buccal swabs are more resistant and stable over time, the whole saliva method yields more DNA and provides a higher concentration of nucleated cells, such as epithelial cells and leukocytes. Now let's move on to prenatal testing options. The first we will cover today is non-invasive prenatal screening, or NIPS. While we often refer to it as testing for fetal DNA, it's important to note that this cell-free DNA primarily comes from the placenta and is found in the mother's blood. NIPS typically uses next-generation sequencing and can be SNP-based. The screening is effective for detecting several genetic conditions. The most common syndromes we look for include trisomy 21 or Down syndrome, trisomy 18, and trisomy 13. We also screen for sex chromosome aneuploidies and other aneuploidies, including trisomy 8, 9, 16, and 22. Additionally, NIPS can identify microdeletions associated with conditions like 22q11.2 deletion syndrome, Prader-Willi syndrome, Angelman syndrome, Crete-Shaw syndrome, and 1p36 deletion syndrome. It's essential to consider several factors when interpreting NIPS results. Pay attention to the false positive and false negative rates, the percentage of fetal fraction, and the potential for incidental findings. The fetal fraction refers to the portion of DNA in the maternal blood that comes from the pregnancy. This is a key quality metric. When the fetal fraction is low, laboratories often have less confidence in determining the sample's affected status. Generally, a higher fetal fraction correlates with more reliable results. NIPS is a valuable tool for screening genetic conditions, but it's important to understand its limitations and considerations to provide accurate counseling to expectant parents. Now let's talk about chorionic villus sampling, commonly known as CVS. CVS is a prenatal diagnostic test performed between 10 and 13 weeks of pregnancy to detect genetic conditions like Down syndrome, cystic fibrosis, and other chromosomal abnormalities. The procedure involves collecting a small sample of placental tissue, either transcervically through the cervix or transabdominally with a needle through the abdomen, both guided by ultrasound. While CVS provides accurate genetic information early in pregnancy, it does have some limitations. Since the sample comes from the placenta rather than the baby directly, there is a slight chance of confined placental mosaicism, where the genetic makeup of the placenta differs from the fetus, leading to inconclusive or misleading results. CVS also cannot detect neural tube defects like spina bifida, which are better identified through second trimester testing such as amniocentesis or ultrasound. Additionally, there is a small risk of miscarriage, estimated at 0.23%, as well as rare risks of infection, bleeding, or limb defects if done too early. Despite these risks and limitations, CVS does offer parents early insights into their baby's health, allowing for informed decision making. Next, let's discuss amniocentesis, which involves inserting a thin, sterile needle through the abdominal wall and into the uterus, guided by ultrasound, to collect a small sample of amniotic fluid surrounding the fetus. This fluid contains cells shed by the fetus, which can be analyzed for genetic and developmental conditions. One of the key tests performed during this procedure is AFP testing, which measures alpha fetoprotein in the amniotic fluid. This protein is produced by the developing fetus and can provide valuable insights into fetal health. Amniocentesis is typically performed at 15 weeks gestation and beyond. In California, it is permitted until 24 weeks, although there is also the availability of an early amnio between 10 and 13 weeks, with most being performed at 14 weeks in practice. The procedure is generally safe, but there is a risk of miscarriage, which is approximately 0.5% overall and 2.2% for early amniocentesis. However, the results are generally highly reliable. It's important to note that if the mother is Rh negative and the fetus is Rh positive, there may be a need for an antibody injection to prevent complications such as Rh incompatibility, which can lead to serious health issues for the baby. The source of the cells analyzed during amniocentesis include amniocytes, which are the skin cells that have flowed off from the fetus, and epithelial cells. In summary, amniocentesis is a crucial tool in prenatal diagnosis, offering reliable results while necessitating careful consideration of timing and associated risks. Moving on, let's discuss percutaneous umbilical cord blood sampling, also known as PUBS or chordocentesis. This procedure allows us to obtain cord blood samples, which can be invaluable in diagnosing a range of fetal conditions. These include infections, genetic disorders like Rh disease, and conditions such as non-immune hydrops. Originally developed in France during the 1980s, PUBS was first used to diagnose fetal toxoplasmosis, a serious infection that can adversely affect the fetal nervous system if transmitted from mother to fetus. Over the years, its application has expanded to include diagnosing fetal thrombocytopenia, a bleeding condition caused by maternal antibodies that affect the fetus's platelets. PUBS is also helpful for monitoring drug levels and managing hyperthyroidism in pregnancy. When it comes to timing, PUBS is typically performed after 18 to 19 weeks of gestation. However, it's essential to be aware of the potential risks involved. These include the possibility of infection for both the mother and the baby, fetal bleeding, and blood clots that may lead to a decrease in the baby's heart rate. In rare cases, it may necessitate an emergency cesarean section. While the overall risk of pregnancy loss is about 1 to 2%, it can increase depending on specific conditions, up to 11% for some infections, and even 31% for cases like non-immune hydrops. Finally, let's talk about maternal cell contamination, or MCC, which is an important consideration in prenatal genetic testing. When a sample is sent for analysis, a maternal blood sample is often included to check for potential contamination and to verify the specimen. However, it's worth noting that this additional step is generally not required for XY samples. In cases where contamination with maternal blood is evident, the specimens may need to undergo culturing. This process helps reduce the presence of maternal cells, ensuring that the test results more accurately reflect the fetal genetic makeup. MCC is particularly common in chorionic villus sampling cases, but can also occur during amniocentesis. To address this, labs store the cultured cells for any necessary further testing, referring to these as hold cells. In summary, understanding and mitigating maternal cell contamination is essential for obtaining reliable genetic test results and providing accurate information to expecting parents. Thank you so much for listening. That's all for this lecture on clinical genetic testing. The next lecture will focus more into karyotype and chromosomal microarray and FISH and other genetic testing approaches. We'll see you next time.